Lasciamo il palco a Ramanan Laxminarayan, che è un economista, un epidemiologo, è il fondatore e direttore del One Health Trust di Washington ed è il direttore del World Health Organization Collaborating Center for Antimicrobial Resistance. Ha fatto ricerche importantissime. A lui si deve anche l'Affordable Medicines Facility Malaria, che è un meccanismo di finanziamento innovativo per i farmaci antimalarici a basso costo e naturalmente efficaci. Dunque, eccolo là, prego, a lei il palco. Grazie, ci rivediamo tra poco. Bene, mi sembra.
Buongiorno, pleasure to see you all again. I hope I can click through my slides here. See if this works. All right, definitely need to see the slides. But again, I wanted to thank all the colleagues here from IZS, Ramo, Alessio, DG, Del Torio. It's been a real pleasure to be here, and it's been great to listen to all of these talks. I primarily work on antibiotic resistance, and just by way of background, I trained first as an engineer. All Indians train as engineers. That's a necessary first degree once you get out of high school. And then I trained as an economist and then an epidemiologist. And I've chosen to work on this particular problem because it really does require a sort of multidisciplinary lens to look at it. I think 25 or 30 years ago when I started working on this, it was seen as primarily a medical issue. But if you look at it as an economist, it is not a medical issue. It's a problem of behavior. Anytime any of us uses antibiotics, we don't really think about the effect that we are having on other people. In the same way that when we drive, an SUV or, we are wasteful with respect to fossil fuels, we're not really thinking about the planet or other people, and antibiotics are very similar in that way. And what makes this a very interesting challenge is that it can only be solved with cooperation. Cooperation is not optional for antibiotic resistance. It is the only way in which we can solve it. So I have to say that it was fascinating for me as a problem, and clearly it is, because 30 years ago it's still what I spend a lot of my time thinking about. So we've not had antibiotics for that long, just to about 80 years or so. This was the first paper that was published by Alexander Fleming, noting the discovery of something that was inhibiting the growth of the bacteria on his plate. Famously, as you know, he went on vacation and he found that there was something growing which was inhibiting the bacteria. But this is sort of the first lesson for me, which is that it wasn't just inhibiting, it was actually killing the bacteria. And the only reason why Alexander Fleming was the right person to figure this out, which many of us would not have, I certainly would not, was that he had studied lysosomes. So he knew killing action, anything which sort of would have taken away the food from the bacteria would have inhibited the growth. But he was one of very few people who could recognize the lysing action of whatever this new, penicillium mold was. And I think that this goes back to the old, saying, which is, fortune favors the prepared mind. And he had been prepared for this. He didn't know when or how, but this certainly helped him a great deal. Now, of course, penicillin was very useful in terms of saving lives, particularly during the Second World War. First World War, more people had died because of infections than of battle wounds. And, this is the remarkable difference in the power of antibiotics of this young woman with necrotizing fasciitis who just in about 6 days, goes from the verge of dying to being perfectly okay. We take this for granted in the way that we take antibiotics and vaccines for granted. We take vaccines for granted. But I don't think people, when they take antibiotics, are realizing that they are using something so powerful, which is before this, we didn't have the power to give life in the way that these drugs are able to. And of course, mortality from pneumonia, which was then a leading cause of mortality, came down significantly. Now, does anyone know the person on the left side? Have you seen a picture of that man? Fleming, Alexander Fleming. Some of you may recognize he discovered penicillin. Now, does anyone know who the person on the right side is? Anyone? Did someone say that? Okay, so we have one person in the audience. Do you want to say who it was? Sorry? You want to say who the right person on the right was? Okay, you know that person. Okay. So the person on the left is Alexander Fleming, won a Nobel Prize, was very famous. The person on the right happens to be an Italian who did something probably as remarkable as Fleming did, but no one really remembers him, given that in a room filled with Italians, not many people know who he was. His name was Giuseppe Brozzu. And Fleming discovered penicillin, Brozzu discovered cephalosporins. And I think, he embodies in many ways for me the spirit of One Health. Because One Health is not just a source of problems, One Health is also a source of solutions. So let me tell you about this man. He was a pharmacologist. He worked in Sardinia at the University of Cagliari. And he was fascinated by the discovery of penicillin. And he was wondering why people who were bathing in this particular, bay in Sardinia didn't seem to get Salmonella typhi, even though they were swimming just where the sewage was falling into the ocean. And he thought there must be one of two reasons. One, the sewage water is being diluted by the seawater, certainly possible. Or the other was that there's something in that which is actually killing the Salmonella typhi. And when he went back and he tried to culture Salmonella typhi from that water, he was not able to. But he was able to find this, which is basically Cephalosporium acremonium, which is what he discovered. And of course, he embodies One Health because he went to find a solution to something he observed. And too often in the way that we do science today, we just build on what the previous paper was, what the previous analysis was. We don't go to nature and what we observe in the real world for hypotheses. And that is very, very important to do, that we don't take the time to go out of our academic settings to go find these solutions. And I think that this is something which we should really take the time to do, because we won't be able to break these silos, as the previous panel was talking about, unless we really go find a different solution. Silos don't break on their own. They're there for a particular reason. Now, his story was very interesting. He then went on to be the president of Sardinia. He was the mayor of Cagliari, the city. He was a rector of his college. He did many things. And of course, he did this as well. And he absolutely changed the world, because without this man, we would not have cephalosporins. But I think fundamentally, to me, this was it. He wasn't just sitting in his lab. Fleming was lucky that he sat in his lab and something floated into his petri dish. For this man, it was different. He had to go and observe something in nature, and he actually walked the sewers of Cagliari with a graduate student. I don't know how many graduate students are here, or how many of them would volunteer to walk inside sewers with their graduate advisor, but I can tell you my graduate students certainly would not. Now back to AMR. Fleming, of course, says, I woke up one morning on September 26, 28. I certainly didn't want to revolutionize the world, but accidentally I did. He's obviously a bit, he was very proud of what he had done. But he also said that it's not difficult to create resistance by, systematically exposing the bacteria to concentrations which are not sufficient to kill them. So I'm going to quickly get to, so this is what bacterial resistance looked like. On the left side, there's killing action of the bacteria. On the right side, there is not. And of course, resistance has always been with us. So resistance was detected in human bone from Nubia, because they probably used something like tetracycline, to preserve food grains. And of course, we see this in the remains of things like the woolly mammoth and fossils. We know that this has always been around, but what we have managed to do is, in a space of just about 30 years, we have taken frequency of resistance from something like 1 in 10 million or 1 in 100 million to now 1 in 2. It's a remarkable, I shouldn't say achievement, but we've essentially destroyed the power of antibiotics this way. So I have here a Lancet series that we put out a year ago in advance of the UN General Assembly. It's all available online for free, but if anyone wants a hard copy, I have a few copies here. And the remainder of what I'm going to talk about is really from that. First of all, resistance is associated with about 4.95 million deaths each year. That's more than HIV, AIDS, and TB put together 2 times. For comparison, HIV, at the peak of the HIV pandemic, killed about 2.1 million people. Now, you remember when HIV was a pandemic, everyone said the world was going to come to an end, 2.1 million people. We have 4.9, 4.8 from AMR. No one's really jumping on the streets. So clearly it's something that we've done a poor job on advocacy. And particularly in high-income countries, these are OECD numbers, you're going to see that number go up by 2x in the next few years. Most of the impact is in South Asia, some in Sub-Saharan Africa as well. But the North Africa and Middle East is also pretty high, as you can see. We are not going to be able to reach our child survival goals if AMR continues in this way. So you can see if we didn't have AMR, we could have met our sustainable development goals, both for newborn as well as under 5 survival. But this is really throwing us off track. And healthy global aging is also not possible when we have AMR, because you can see for the above 65 population, all-cause mortality in above 65 population in South Asia, something like 12% is just because of AMR. Now, we developed an index, which is like a stock market index, which is actually quantifying resistance into a single number. This was then put out by the Financial Times. They do this periodically. The research is done by our group, but they put out the numbers, in the newspapers for the public to see. And you can see that resistance has been going up in many places, but particularly in countries like, Russia, Pakistan, India, Venezuela, all of these are the countries where things are pretty bad as it is. So it's basically a weighted average of resistance, weighted by how frequently that antibiotic is used. Now you can see that after ischemic heart disease and stroke, if you include the numbers which are associated with AMR, this is now the number 3 cause of death in the world. The number 3 cause of death in the world. And it's a serious issue. On Monday, which is in 2 days from now, there will be a new World Health Organization report which will show that things have gotten even worse with respect to AMR in most countries around the world. And we continue to lose the power of antibiotics, even though we're supposed to be finding ways to reduce that number. Urinary tract infections. Now, UTIs, you generally see young women have it, but keep in mind for all the older folks, above the age of 65, men and women have equal chance of getting UTIs. And many UTIs are not treatable anymore. In many countries, you would not have thought that a urinary tract infection would kill people. That seems kind of rare and unlikely, but it's increasingly common in many countries. Now, this is an interesting picture because it shows the number of drugs that we had to treat gonorrhea, 0 in the 1920s, but we're now back to 0 in terms of a reliable drug that will reliably treat gonorrhea. So, when I first presented this, I think a journalist wrote that, the best time to have gonorrhea would have been in the 1980s. But of course, there's no good time to have gonorrhea. But if you had to have it, 1980s would have been a good time when there were drugs to treat it. Right now is not, we really don't have effective drugs for gonorrhea. Meanwhile, this is an important slide. This is in the Lancet series. Look at the price of antibiotics right up to 2000. They're all about under $100. After 2000, the price goes up. The price of new antibiotics introduced since 2003 is between $5,000 and $15,000 a treatment course. $5,000 and $15,000. Now, there are very few people in the world, forget about countries, very few people in the world who can afford that for a 5 or 10-day course of treatment, right? But this is what we're up against, and we have to recognize that if we continue down this path, that's going to keep going up. And you have to think, are you prepared to spend $50,000 for the next course of antibiotics? I'm not so sure. We're using antibiotics widely. This is from a range of studies that we've done in animals, humans, and the environment. We're using antibiotics in humans, but also in cattle, also in chickens, also in pigs, and some in fish, in aquaculture as well. And of course, the bacteria don't stay in just one place. They move around. We live in a sea of bacteria, so they are moving around, and so it isn't as if just one sector affects the other. They all affect each other. Now, if you thought of one species that uses the most antibiotics in the world, it is pigs in China. Pigs in China consume more antibiotics than any country, any population in the world. It's not changed a lot. It is reduced for colistin, but not so much for anything else. And as a consequence, this was a study from a few years ago that we did showing that antibiotic resistance is a problem for the animal sector as well, to treat sick animals. We think of AMR as just a human condition, but it's actually a problem for animals when you can't treat them. And you see resistance has been going up in nearly every category. In cattle, not so much, but certainly for pigs and poultry. Meanwhile, if you are in the business of developing new antibiotics, it's a very, very difficult business to be in. I was in a meeting just 3 months ago back in Italy at a company up in Siena, looking at ways to solve this problem. But interestingly, in any other category of drugs, when you come up with a new product and you get an FDA approval, your stock price goes up. In the case of antibiotics, you have an FDA approval and your stock price crashes and you go bankrupt. Most companies making antibiotics now are going bankrupt because it is not possible. It's a vicious cycle. You make an antibiotic, you have to sell it at $10,000 or $15,000 to make your money. You go offer it on the market. Nobody wants to buy a $15,000 drug. Therefore, you don't make any money, and therefore, you collapse. So we have not solved this problem of who's going to pay for new antibiotics when they're really so expensive. Because where are the people who really need the drugs? They are not necessarily in high-income countries. They're in places like India, in Brazil, in South Africa, in Nigeria, in China. But these companies are not going to those places. In fact, most new drugs don't reach more than 10 countries. Any new drug usually reaches just the high-income countries, and usually about 70% of the drugs have not reached more than 10 countries after 10 years of the product being introduced. So we're developing drugs, but most people will never see them. That's not a good way to do business or to solve public health. Meanwhile, all the antibiotics, where do they go? They go, we excrete them from animals, from humans. They go into the rivers, they go into in China, they go into all of the river basins. And that's 54,000 tons of antibiotics which go into the environment and to the river basins, which means that they're back there creating resistance again. This is also creating resistance genes in swine farms. When they culture and they sequence the resistance genes in the Chinese swine farms, they find from a 192-fold to a 28,000-fold enrichment of the top 63 ARGs. And you find every kind of resistance mechanism there. Every antibiotic is represented in there. So this is what you see not just in China now, but you see this in many countries around the world. Now, here is a study that was only possible in the Netherlands. In the US, we can't do this study because under a budget cut under a previous administration, which we won't talk about, we basically destroyed all of our samples of soil, which we've had in the US since 1930s, actually. But Europe still has these soil samples, and you see that just in regular soil samples, concentrations of beta-lactamases, tetracyclines, erythromyces have all been going up over time. So it's not just in the environment, it's actually accumulating in the environment. Now, it's also in the water. In India, for instance, we have these mass bathing events. The Kumbh Mela, some of you may have heard of this, 15, 20 million people, sometimes 40 million people go to bathe in the river on one single day. Now, what does that do? It vastly increases the number of resistance genes. So NDM1 is about 20 times greater in the Ganges during the pilgrimage season than at other times of the year. And we see that by comparing in Delhi, where there is no such bathing event. You don't see that increase in NDM1, but you see it in all the other places between the bathing season versus the non-bathing season. So it's very much in the environment. It's also in selected aquatic environments. In industrially polluted water, the typical concentrations are the same as what you would hope to get in a patient's bloodstream if you were treating them with antibiotics. So those are the typical minimum inhibitory concentrations, and same for untreated hospital effluent. So what's in the environment and the water is the same concentration that you want to have in a patient. That's not a good thing. Not a good thing. We have interesting ways of doing surveillance, which are now doing it in much more of a One Health way. I think these are the positive ways in which we're thinking in a very different way about AMR. This particular study looks at global resistance genes and pathogen surveillance using the toilets from aircraft that fly into Singapore. So all of the Singapore Airlines flights, they take out the toilets and basically are looking for the resistance genes, and they can see where that flight came from. So sitting in one place, you can actually now global surveillance is possible just from one airline. It's also happening in some other countries. So I think we're being very creative about how to solve these problems as well. But you see from these kinds of studies, this was not done from that study, but a similar study by Frank Arstrup. Sorry, it's small, but you basically see high concentrations of a variety of resistance genes across all countries, but particularly in many low and middle income countries. You see that, a significant amount. But this kind of genomic surveillance is now becoming quite widespread, and it really gives us a handle on how bad the problem is getting. And until now, we were flying blind on this problem, but now we know a lot better. Now, as the planet warms, we have pretty good data. This is an older study from my group, but there are other studies now showing that gram-negative organisms tend to be more common when temperature is higher. We don't fully understand why. It's something perhaps that some of you may be interested or already know the answer to. But when we start seeing that, and gram-negatives also the place where we don't have too many antibiotics, then this is something that we should be very concerned about, because this is where drug development is not really keeping up at all. So climate change, we already see this as an issue. This is an excellent study done by McFadden and other colleagues looking at the minimum temperature in a place and resistance levels, and again, resistance is going up. Now again, when we observe these correlations, we don't, A, know if it's a causation, and second, we don't understand why this is actually happening. But these topics which are connecting climate and AMR and particular bacterial pathogens are actually, ripe for study. I think people can make scientific careers studying this sort of thing. Last, I'll end with a slide which is not from the state of antibiotics today, but this is as you can see, from 1899. So this man, he's in Atlanta, Georgia, and he's basically, he's outside of Atlanta, I guess he's in Athens, Clark County, and he's basically exercising on a plot of grass, and he just gets cut a slight bit, he develops a bloodstream infection, but this is prior to having antibiotics, and the foot has to be amputated. Now, this is not just happening in the past. In many places around the world, this is happening quite regularly, and this is not just in poor countries, it's happening in high-income countries as well. So AMR is no longer a future thing, it is something that's there with us right here, right now, and it is invisible only because we choose not to see it. We don't wear a pink pin saying, we are fighting AMR, but our animal, human, environment sectors and plant sectors are all very aware of this particular problem. And in fact, this is like climate change, not one that we can solve on our own. This is the UN General Assembly, where both in 2016 and 2024, there has been a global commitment to reduce the burden of antibiotic resistance by 10%, improve the use of antibiotics, and also substantially reduce the use of antibiotics in animals, which I think is very, very possible using animal vaccines and other measures which are there right now, and certainly an area for research for places like our host this today. So with that, let me say that a lot of the data we aggregate at this website called resistancemap.org. It's also available, and there are different other sources of data as well. I think the only way in which we can bring some light to this problem is by bringing data and what we can do as a scientific community to help solve this problem. But again, going back to our friend Giuseppe Brazzu from Sardinia, we can't ignore the politics. We really have to engage in those domains as well. If we just stay writing in journal articles alone, we're not going to have the impact that we will by engaging in policy conversations. So thank you to all my colleagues, thank you to Alessio for inviting me, and it's been a great honor to be here, and thank you very much.
Thank you. Grazie Ramanan Laxminarayan. Grazie.